Good morning. I'm glad to be here as part of this panel. I'm going to focus my talk on a more practical discussion on how to set up a post-surgical care pathway. I have no disclosures. When I arrived at Emory about 11 years ago, there really was no sexual medicine program in place, let alone a sexual rehabilitation program, even though we were providing high-volume prostate cancer care, largely because nobody actually believed that their care resulted in any erectile dysfunction for their patients, but it was also an out-of-sight, out-of-mind situation where patients themselves were not returning or complaining of their sexual side effects, and so their clinicians were not aware of the necessity of such a program. And what has really helped me champion this program, and we have come a long way in the last decade or so, has been the patient partnership and patient advocacy for this care for themselves. So I put on this slide, first and foremost, convincing the patients of a benefit of such a program, then convincing your colleagues, your surgeons, your radiation oncologists, really the entire team that you're working with about the benefit of this program in terms of long-term patient satisfaction, and lastly, convincing the institution. We often think of that as being the rate-limiting step, but that should really be the easiest step if everybody else is on board. In looking for kind of a gold standard example of what a program like this should look like, I came across this example from Michigan, and Dr. Wickman is here as an author of this paper. And this should not be an intimidation type of slide, in the sense that it can seem overwhelming to think of the resources that you would need to set up a program that looks very much like this. But there are bits and pieces of this that we can start with. We can all start with, depending on the strengths of our institution, and really get it up and running and be a very functional and successful program. You'll see on here highlighted the importance of that preoperative evaluation, as Dr. Bober just took us through, and then the steps that follow in the perioperative time period, and then shortly thereafter in terms of more intensive work on the sexual recovery. So data from the same paper, again, highlighted the importance of that preoperative visit and how valuable it was for both the patients and their partners, over 95% satisfaction rate for both. But really that same trend continues for the postoperative counseling visit and then subsequently meeting with the sexual therapist. So every part of this component of this program is valuable, and even if you cannot start it in its entirety, at least start one portion of it. I also want to emphasize that partners play an essential role, and we have seen this time and time again. The role of the partner changes very much during the postoperative recovery of that patient. Sometimes they are the caregiver, sometimes they are the cheerleader, sometimes they also have to be the boss and tell the patients what they need and what they need to do for their relationship. And it is essential for us to support the partners through all of these roles that they're simultaneously playing in the postoperative period. Educating the partner certainly enhances the recovery of sexual function for our patients, and supporting the partner definitely improves the management of sexual function as well as the expectations for that couple. On the left, the paper that I have shared is actually our study from the initial Movember trial, looking at how much satisfaction both patients and partners can derive from an intervention that's focused on survivorship and sexual function recovery. And in that paper, the importance of getting information at every step of the way, preoperatively, perioperatively, and postoperatively, was highlighted as the most important benefit of a sexual function intervention. And the second paper on the right really addresses that partner needs continue to remain unmet in the majority of cases, and how detrimental it can be when the partners themselves feel invisible and feel that their role is either not taken seriously or that they're not supported enough to be able to then support the patients that we care for. So practically speaking, what do you really need to get this intervention off the ground? For us in the beginning, we did not have all the fancy resources from that slide that I showed you earlier, and we started just with a urologist, myself, and an APP for support. We had a sexual therapist, but not somebody who was embedded in our program at Emory, someone in the community, and we had a nurse navigator, and it was enough for us to get our program up and running, at least to convince the patients of the importance of this type of program. And from there, we have really grown and added bit by bit the other resources that have made us successful. What should a program like this be able to do? It should really give you support for all aspects of sexual dysfunction, as well as andrology, including hormonal therapies for patients that need those. You should be able to support outpatient procedures, for example, management of Peyronie's disease and ICI teaching, and then surgical procedures as well for the patients who go on to need implant placements, for example. What should be on your wish list, which you may not see right away, but these are all important components to include. A physical therapist, again, would be a wonderful addition, and we have that now. We didn't in the beginning. Radiation oncologist, certainly somebody to partner with and help your patients when they are counseling them about the side effects of radiation therapy. Medical oncologist, and a gynecologist for the partners as well. And if you can get all of these players on board, then you're really, really in a good spot in building a sustainable program. And how and when. So accessibility is key, and I think this is very, very important for our patients to know and feel that they can get to us whenever they want to or whenever they have questions. You want to be able to have a pre-surgical, post-surgical visit. You want to be able to tailor recommendations to your patients' needs, obviously, which differ very much from couple to couple, and most importantly, normalize this very emotional response that happens to sexual function changes. In the early postoperative period, the first 0 to 6 months, we focus primarily on sexual dysfunction treatments and use of sexual aids, and then in that later half of that year, really focus on sexual recovery and what long-term function may look like. And these treatments have been found to be not just feasible, but also scalable and adaptable to your particular environment. These are examples out of Canada, where one intervention looked at acceptability of an online type of program for men and their partners in the community, with over 70% of these patients successfully completing the entirety of the program. And the paper on the bottom really talks about how online interventions and training can also be used to train caregivers to provide and set up this type of program and support it long term. So I know I'm at time, so I'm not going to go into details, but thank you for your attention.